Welcome to Free Flow, the Health Tech Law and Policy podcast, where we explore developments in health policy and help you navigate legal and compliance issues that affect your business. I'm your host, Dan Orenstein. On today's episode, I'm joined by Keegan Bailey, co-founder and CEO of VitalFourth, a not-for-profit management service organization focused on virtual maternal collaborative care, and project executive on RI Spheres, an NIH-funded initiative focused on innovative ways to help new mothers with postpartum hypertension and related conditions. Keegan brings more than 2 decades of experience at the intersection of finance, data strategy, business strategy, and health policy in a number of public and private roles, including at the New York State Department of Health and as CEO of Acuitas Health. Hi, Keegan. How are you?
Good.
Welcome to Free Flow.
Thank you.
Glad you could join today. We're going to talk about this amazing, highly needed postpartum remote monitoring program that you're engaged in, and maybe some other stuff that you're involved in. You're always someone with a lot of projects going on. And I want to hear from you on this and like how you identified this project. It's called VitalFourth, right? And how you identified it, and then we'll get into some of the challenges you're having in rolling that out. So maybe we can just start by telling me what it's all about and how you landed on it.
Sure. Thanks, Dan. Happy to. So VitalFourth is the kind of commercial version of a 4-year-old research project, and there's several iterations of that with the National Institutes of Health. And on its surface, it would seem that, remote blood pressure monitoring program for high-risk maternal health is a very kind of a niche thing. But the reality is that more and more moms every year are impacted by hypertension. In fact, data shows that between 10 and 12% of birthing moms, the reality is
I would never have guessed that, because
it's actually higher.
Hypertension always seems to be more of like a male issue in my mind, but I'm uninformed. So
yeah, no, it's actually higher because day to day what we see in the data, because keep in mind, the data, this is data reporting to state public health agencies, it's data reported to the CDC, data reported to ACOG, but what we see on the ground is more like 20%, between 20 and 3%. Okay. So it's tremendously high and increasing, and no one really knows why. Some people think it's air quality, diet, culture, right? It could be a bunch of things. But I was fortunate enough to meet Dr. Adam Lukowitz about 3 years ago in Rhode Island, who had been studying and researching this for a while. The problem spoke to me as a public health professional, someone that had worked for state Medicaid, realizing that a majority of these moms are in Medicaid or uninsured.
Right. And Dr. Lukowitz is a researcher and a physician at Brown?
So at Brown, Care New England in Rhode Island, specifically Women and Infants Hospital, one of the largest birthing hospitals in the country.
Got it. Okay. Yeah. And you were saying, so large Medicaid population there.
Yeah. We estimate that our current cohort is about 50% Medicaid, and then you got a portion that's uninsured, and then a portion that's self-pay. And as we know, the state or the state of policy and insurance in that regard constantly changes those numbers, not in a patient's favor.
Right.
At all. So those are all dynamics that we're dealing with.
Yeah. So you've identified this problem, a clinical problem, where you have an intervention of remote monitoring, which can be really impactful for a primary condition, but also comorbidities, right?
Correct.
And so maybe tell me a little bit about, we don't want to get too into the clinical detail, but some of the comorbidities and what this program, like how it's structured and how it can have a positive result on outcomes for postpartum women.
Sure. So I think first and foremost, I think there's a tendency, especially in our kind of tech forward world, to think about the monitoring piece of this. What this really is, the tech-enabled clinical intervention. And so what we have is a collaborative care team that includes, a physician, so the obstetrician, and we have a nurse practitioner, social workers, we have a patient with lived experience, and they collectively manage the patient population day to day. And the idea is to provide an intervention between birth and everything else, because typically that period of time could be 2 weeks, 4 weeks, 6 weeks before someone can get an appointment after birth, either with their OB office or the primary care clinician. There's a gap. And during that period of time, patients have adverse events. They get admitted to the emergency room, some die, some,
And are
develop.
these things kind of caused by or exacerbated by hypertension?
Caused by hypertension. And then there are social and behavioral health and like lived experiences that
Contributing factors.
contribute to hypertension and other things. And so
Okay, okay,
the
okay.
program's the recognition that it's not one problem, it's a bunch of things, and that there is a definitive clinical thing that we can focus on as kind of the gateway or the entry point to address a more holistic view of what the
Right,
patient is
right.
dealing with. Yeah.
Okay. Okay. And so tell me a little bit about how you formed your organization to address this and why you did it that way. Because you have, I would imagine, several options in your arsenal or toolkit.
Yeah.
You could do policy advocacy. You could, create a company. You could go in and do what you did, which is a nonprofit organization. So tell me a little bit about how you chose your method of approach.
Sure. So I think the best way to describe what we're doing is an opportunity to bring policy into action. And so what I mean by that is, there are a lot of kind of interventions tailored around high need and Medicaid populations, but what we have here with the RA Spheres research program and the VitalFourth kind of not-for-profit incarnation of this is a working model that's producing results every day,
Mhm.
that is scalable in its virtual nature, and that not in theory can have impact, but is having impact.
It has measured,
Measurable
demonstrable impact,
every
right?
day. And that's kind of one of the benefits of kind of building off a research project or research program is it's highly data driven. And so we know definitively how many moms are impacted every day. We know that we know their satisfaction with the program. We know how usable our solution is. We know how many moms have been admitted to the emergency room, how many moms haven't. We know the referral rates to primary care, right? We have a lot of data on like all of the experiences, a lot of things that aren't typically measured with technical interventions in the market or even care interventions in the market. And so we have that evidence base to build from, and it's compelling. It's compelling because we see it every day. It's compelling because it represents a gap in what's traditional for a hospital to provide, for an OB practice to provide, for a primary care practice to provide. And so, the real world nature of it is compelling, and best advanced in the form of this not-for-profit entity, and we kind of talk about why that and
Got
other.
it. Got it. So it seems like this is a intervention that has demonstrable positive impact based on the data and the studies. And so the next question is, so why doesn't it just get rolled out everywhere? But you could probably say the same thing for a lot of different interventions and programs. So there are things that are competing to get pushed through, and there's different barriers or challenges to get them through. And so it seems like here one of them is adoption and the culture, so we're like remote versus in person. And then there's some others. Well, I want to get into like regulatory and funding, but let's hit those in sequence. So on the culture and adoption, so I understand that there might be a bias towards in-person blood pressure monitoring in some of these hospital systems. And maybe you can talk about that a little bit, and also like talk about what happened coming out of the pandemic when everyone went remote, and then it kind of the pendulum swung back. And then where does that leave us with an intervention like this?
Sure. Yeah, so our system's highly geared around in-person care. That's it, right? And if not, we would see more virtual things. I think we've seen more virtual things since COVID, but it's interesting being, during COVID, I was kind of living the scheduling and revenue cycle reality of a multi-specialty group, and you could see the numbers, right? Kind of a few virtual visits and all of a sudden spiked, and it spiked because we had to, right? And everyone's like, oh, what's going to happen when the rules relax? It'll never go back to the way it was. But sure enough,
Right, right,
dropped it, like, dropped free fall, right back to where it was. And all of the payment incentives are geared around in-person visits, all of them.
right.
And that infrastructure did not change. And there's this dimension of,
It didn't even change just a little bit, like towards making it easier to have in person. I mean, remote versus in
I mean,
person.
think about this though. Like when you go to an office, like the entire infrastructure is geared around in person care, right? The secretary, the lease,
Right,
right? The kind of filling a schedule in the office, the things they need to use in the office, right? There was no it was there's no infrastructure building to get that
right.
right. And so you see, a ton of like behavioral health virtual companies pop up, and I think that's largely driven by workforce shortage. And but even today, you can see there's also a human, and I'm not gonna knock it. There's a human need
Right,
for
right.
interaction, and that's super important. So I think that has something to do with it too.
Sure, sure.
On the other hand, what I think was missed tremendously is using virtual care as a way to fill gaps in the system, because they still exist, right? Those gaps didn't magically disappear. And maternal care is a perfect example. There's not one
Hmm.
practitioner or professional in the maternal space that I talk to that doesn't vigorously nod their head when I say there's a chasm after birth. They're like, yeah, duh,
Hmm.
right? And so it's a perfect
And
example.
in person isn't about to come in and fix that. There's like
No,
no
there's no
efforts
incentive.
underway to like
There's,
deal with that first 6 weeks postpartum.
I mean, yeah, I mean, certainly
Some, maybe some.
there's some, but they're geared around in-person care.
Yeah, yeah.
Right. And so it's like, yeah, we have a postpartum program, and then they start describing it too, but yet still there's like within, you know, specifically with blood pressure, if it's not monitored within the first 24 hours, bad things happen. And
Yeah,
our
yeah.
system is not respond. I mean, think about it, right? Like when you schedule an appointment with a doctor or a nurse, like, is it ever the next day?
Yeah. So maybe let's get into the next challenge, and then let's get through the challenges, and then maybe you can talk about how VitalFourth is thinking about addressing those, because you have to address those to get your program adopted, right?
Yeah.
And the reason I want to do that is because you may have a method that hits one or more of them rather than one at a time. So let's get into reimbursement, which I know you're an expert at, and like how these things get paid for, and what you're seeing there as an obstacle.
Sure. So interestingly enough, it was only recently that state Medicaid programs reimbursed for postpartum care writ large at all.
Right,
A year
right,
of it. Now it's due to some federal action that is now possible. Now, what isn't prolific nearly, at about 40 to 44 states, is reimbursing for virtual care
right, right,
in Medicaid. So that's relatively new. There is a recent focus on maternal health and hypertension and things that are virtualizable. And so,
right,
the beauty is that there's state policy for that now. The challenge is that, even though, there's policy and there are codes and there's reimbursement, the implementation state by state varies. And here's an example. So New York State tends to be one of the higher, kind of states with more stringent regulations. They have forced, because most states are Medicaid managed care now,
right, right,
right? New York State has forced the managed care organizations to adopt said payment policy and allow payment for these codes.
Hmm.
And it's just kind of interesting to see that specifically written in like 2 paragraphs because,
Because it's on the books, but they're not doing it, in other words.
right, like make me.
Yeah.
And so you see that and that variation state by state where it's like, and it's almost like durable medical equipment where it's just like,
Hmm.
yeah, we said we'd do it, but like no one's paying for it.
Sure.
And
That goes with like the cultural obstacles or the traditions kind of have a long life and a life of their own, maybe.
correct. Yeah.
Yeah, so there's reimbursement. So the codes are there. So it's not the fact that you need the codes or can be reimbursed. It again, it almost seems like a cultural or an advocacy issues, like behavioral issue. Like get the stuff done, bill,
Well,
you can bill for it.
I'd say organizational behavior issue, not necessarily
Okay.
a medical one, right? And what
Not
I
individual. Yeah,
not individual.
organizational.
Yeah, this is like big organizational psychology, right? Where, you have momentum around, where the money is coming from to keep the hospital system going. And I think there's an increasing awareness and interest in
Yeah.
virtual programs, and we're seeing it. And I think, states, it's interesting because the Rural Health Transformation Program, you may be familiar with at the
Yeah.
federal level,
Yeah.
the 50 billion, right? So those funds are kind of rolling out in various forms. But what's interesting about that, absent that program, is that in states like New York that have large rural populations, there's a history of closing birthing hospitals. Right.
Right.
And so some
Right.
states have created things like, regional perinatal centers where, in theory, there's an anchor hospital that can provide more services to
Hmm.
compensate for the lack of birthing care. Now, that still means that today in some parts of Western New York that you have moms that drive 2 hours, and that can be deadly for someone that has a complication,
Yeah,
right?
that's
And
a long
so,
time. Yeah.
when we talk to, and our program and invention and model is ideal for those scenarios, right? Because we can
Hmm.
be virtual, it's easily scalable, and when we
Yeah.
talk,
Yeah.
when we talk with these hospitals, what they tell us is that, oh yes, we want to add this to our quiver of remote things we're doing like radiology and other things
Hmm.
for this population. So from that perspective, it's not a hard sell, and consistent with other
So
kind of
that's the
healthcare.
hospitals that you're talking to. But so once you have that level of interest and they acknowledge this is a good program, then what? I mean,
Yeah.
is there still
So
a barrier to getting it
sure.
adopted within that system?
Yeah, and it's about resources and money
Yeah.
because
Hmm.
even though there's tremendous interest, there isn't the staff, and so what we're typically
Right.
doing, partnering with these teams on, funding opportunities because reimbursement is insufficient to get a program like this off the ground, right? We have to hire staff, we have to buy devices, we have to, kind of deploy the program. We don't just have like a large cohort of nurse
There
practitioners,
are things to operationalize it
things
as
to
well. There's a lot of
operationalize
work to be done. Yeah.
that reimbursement does not address. And so we are looking to other sources of funding, in concert with our hospital partners that are very excited about our program. The proposals
Yeah.
are more attractive with that type of support.
Yeah. So okay. So that's great. I think we've probably hit the major barriers, right? Organizational, behavioral,
Well,
cultural,
I'll highlight,
reimbursement,
I'll highlight,
operationalization. Yes, go ahead.
yeah, yeah. Back on the operational side, and this is a bit more granular, but
Yeah, yeah,
it speaks to how we've intentionally designed our program because you could say, right, you can give a patient anything and expect things to happen, and they don't, right? We do that in healthcare all the time.
yeah,
Just go do this. And we don't have that problem. And we don't have that problem
yeah.
because, we've kind of stripped out all the things in remote monitoring that cause problems.
Yes,
And an
great.
example of that is, I'm going to give you a blood pressure cuff, and then you have to connect it to this, your phone or another
Yeah,
device, right? And what you've done when you do that is you created another point of failure, right? Because if that connection does not work, your program fails.
yeah,
And
yeah,
run programs like that in the past that have failed. And so what we said was, is there a way that we can remove the friction for the patient? Make this so simple that all they have to, we're going to explain the program, we're going to recruit them, but all they have to do is put the blood pressure cuff on on and turn it on. That's it. And take a reading. They're going to get a text message
I
to
love
remind
that.
them to do it.
Yeah.
That's it. There's literally no other friction. They just have to remember to do that. And we're going to remind them to do it multiple times. Right. But, they don't have this to deal with. They don't have that connection to deal with. And we're going to give them an advice that's so easy.
And so
to
you've shown then on the patient compliance side, really strong
Yes.
uptake. And that's not a significant barrier because you've addressed that. And I would also observe that that's something that you've been able to address yourself with the technology and the process. And you haven't had to rely on a large organization or a funding source for
No.
that.
No, we actually made some significant product and engineering changes to make that possible.
Yeah.
The text piece, the reminder piece, like removing the app, like, oh, we have this beautiful app. Don't you want to see it? No, I don't. I don't want to see it.
No.
I don't want to see it. It's just, and that comes from, and you can relate to this, right? I mean, I worked for NextGen for 5 years. You worked for an EMR vendor, right? Like everyone's
I can totally relate. I'm trying to put my phone down as much as possible now. Read paper books and stuff.
Yeah. Just use the personal health record. Everyone uses it.
Yeah. Yeah. Totally. I totally get that. Okay. So that's the patient side, but let's get back to the organizational and the funding. So give me, tell me about how you're thinking about those challenges and addressing those. And some of them are kind of, I would say it seems on the operational side, getting your own funding to be able to address the operational issues and push into these organizations. But, maybe, give me the top 2 or 3 things that you're doing to try to address this and get this adopted in the hospitals you're talking to.
Yeah. So we could choose to take a traditional kind of technology and infrastructure hands-off approach to this because that could be more lucrative. But the problem is it doesn't address some of these barriers. And one of the key barriers is finding a person to do the care, to provide the care. And we know from experience and by, from data that the hospital is not going to do that. The primary care office isn't going to do that. Right. And so we're making a choice to do that, even though, it may not be, profitable per se. I think as, and this kind of goes into the logic of why a not-for-profit, because we want to be able to sustainably provide the care, provide the supportive technology, and provide the intervention because,
help me understand a little bit when you say provide the care. What do you do when you come into a hospital organization? Because they've obviously got all their clinicians and staff there.
They do. Yeah. So it's a gap filling intervention, and what I mean by that, and provide the care. We're not providing primary care. We're not doing like the full battery of obstetric care. What we're doing is titrating medication. We're doing social needs screening. We are counseling on medications. We're referring to behavioral health, right? It's connective tissue. And kind of we're reviewing blood pressure readings. So
you're creating that program of kind of holistic care for this issue and then bringing in kind of integrating providers and
referring to primary care, right?
We're medication, so forth.
Right. Yeah, we're doing like what needs to be done to keep this patient out of the hospital and stable and connected to the right parts of healthcare when the system doesn't do it. Right. And, I think you could find examples of, in primary care, like in a federally qualified health center, where they're very well-oiled machines with kind of referrals and comprehensive care for a patient, but even they would recognize that there's a form of this connective tissue that's missing because they also have their full schedules every day. They're also not paid, to spend pajama time, calling patients.
Yeah. So in terms of, how do you get paid? Like just boiling it down, just isolating the financial incentives or funding, how do you get paid? And then also what incentivizes the hospital providers to engage with your system?
For sure. So in terms of the how, right? So not-for-profit managed service organization, MSA with billing Medicaid provider, right? Maybe we create a PC for that or have multiple MSAs with multiple PCs, but the MSO takes on billing, provides that infrastructure for the billable provider, and we bill Medicaid. for the remote
Okay, got it.
monitoring
Yeah.
folks. Yeah. And there's actually another dimension here. So I think I mentioned we estimate about 40 to 50% of this population that we're serving, this 800,000 to a million high-risk moms a year that we're serving that are Medicaid. There are other moms that could self-pay or are uninsured at all. And I think that's another kind of reason for the not-for-profit, because we can seek non-dilutive funding to cover those patients for free, which we feel is a really important thing to do. And so, in terms
Got
of
it. Got it.
getting paid and revenue, it has a different flavor depending
You're not
on.
in commercial? Are you partnering with any commercial payers?
We haven't focused on commercial payers yet. There's no reason we wouldn't. This feels a lot like a kind of health savings account reimbursed thing than it does
Right.
a core part of like a benefits design. But it may be.
Okay.
It kind of depends. We have engaged with several insurers like Blue Cross Blue Shield of Rhode Island about maternal care. But again, like they're looking at like their Medicaid line of business and maternal care against like Medicare, and
Right.
other bigger spending buckets. And so it can be a little challenging to get their attention. We know we can have impact in the Medicaid and underserved populations.
Yeah, that makes a lot of sense. So is there anything else you're doing to kind of address these challenges of adoption and, organizational behavioral change?
Yeah, I think, like on that, I think you had asked like why would a hospital agree to work with us? And Adam and I recently had a hospital CEO ask, well, this sounds all great, but like, what's my risk? Like, why would I refer to you? Because that's effectively what we're asking, right? Or we're asking, their hospital teams to refer to us immediately.
Right.
And work with us. And the answer was, oh, well, you might find a primary care provider or two that would be worried about, kind of billing for a postpartum visit. And it was interesting because the hospital CEO like smirked and looked down. He's like, it doesn't happen. And no, this is additive and helpful. And that led into a reason why he thought it wasn't a problem, because it does wonders for hospital patient satisfaction, right? Right? Because those rates can be very low. Coordination in the hospital stinks. And hospitals are incentive for financially for those scores to be high. And so here is a wonderful, pretty much free opportunity for them to refer, engage with us, and fill a need for their patients.
That's helpful. That's very helpful. So let's zoom out a little bit and into like the policy sphere. So you're not the only like really helpful or impactful intervention out there. What are the few things that policymakers or payers or whoever in the hospital executives in the ecosystem could maybe do from more of like a policy level to encourage and promote these innovations, getting integrated when they are demonstrably, good demonstrable outcomes?
Yeah, I think a big thing is, and I'll put in air quotes, startup funding, right?
Yeah.
Reimbursement does not address that. That's like once you're going and can sustain the program, but
Sure.
you need to hire nurses, you need to operationalize, you need to buy devices, like all of this stuff costs money. So I think, there, and we are pursuing state funding pools and grant pools that can help with that, but that's essential. The policy, reimbursement policy itself is not sufficient for that to happen. I think the other thing is to
and well, let me just stop you for a second there. And are you thinking about kind of more public sources of funding for that, or maybe encouraging hospitals to invest more, like some incentive programs or something like that?
Yeah, absolutely. Yeah, whether it's through their foundations or whether it's through their pursuit of, kind of public benefit or public health oriented funding pools.
Okay.
So there are safety net programs and rural programs and quality oriented programs. Some of those are under stress right now due to federal policy,
Right.
Medicaid.
Right.
But, absent that, the need doesn't go away. There are still incentives and disincentives for reducing readmissions, for improving quality, for and more, believe it or not. And it's kind of it's good, but unclear why there's an increasing focus on maternal health in particular.
Hmm.
Especially Medicaid. I mean, think about the history of Medicaid, right? Like it grew out of a mom and kids program, right, to
Yeah,
cover
yeah,
everyone. So, kind of back to its roots in that regard.
got it. Yeah, excellent. All right, anything else
Oh, so much more to
on
talk
this?
about, but like,
Anything else on this topic that we might have missed?
yeah. So, it's interesting. I'm giving you, Dan, some of the background on like, our journey from, public benefit, corporation, ignoring S corp, incorporating a not-for-profit MSO. Like, what is your take from a legal and policy perspective on our journey? And I mean, you've seen a lot of parts of healthcare and probably have clients doing, you know, parts, implementing some of these organizational strategies. And
Yeah, I I think that it's, as you were mentioning, and I've observed, like venture funding, public funding, reimbursement, they all have their pros and cons. They've all got their limitations and maybe applications. And it's good to be aware of what path you're going to take to achieve your goal. I think culture change is really tough because you don't find yourself with the ability to really influence that when you're in a position like you're in, where you're a startup trying to get a technology or a set of services or an intervention adopted. That's great to talk about, and that's more of a political conversation. But I think you're left with kind of what are the strategic options, what are the best ways to evaluate those, and then to some extent, how can you push on policy levers through associations and third parties, often at the state level, to get some of these things, and especially where there's a clear consensus or a group that's, a consensus about what needs to be done to improve things. But I think it's a bold endeavor that you're in to try to make this happen,
thank you.
and hope it happens more, and that you're successful, and that you successfully get through these barriers, because it's badly needed. Um,
We're seeing great traction, and I've linked with the New York State Perinatal Association. We're now like invited speakers at a lot of the perinatal center annual conferences. We're connected with women's health kind of conference series that's kind of made up with folks. There's actually an advocacy day in DC in September. So we're
that's
trying
great.
to like implant ourselves in the conversation in the community and getting good responses. So that's super helpful.
Terrific, and best of luck with that. And thanks again for joining the podcast. Really
Sure.
appreciate it.
Thanks for having me.
And that concludes our episode of Free Flow. Thank you for joining us today. For more information, please visit our website at orensteinlegal.com and navigate to the podcast page. Remember to subscribe or follow Free Flow on Spotify, Apple Podcasts, and YouTube so you never miss an episode or update. This podcast is for informational purposes only, is not legal advice, and does not create an attorney-client relationship. Thank you for listening.